Assalamualaikum warahmatullahi taala wabarakatuh, and very good morning to all of the audience. I am Dr. Asma Abdullah from Departments of Otorinolaringology, Head and Neck Surgery, Fakulti of Medicine. Today is a clinical pathological conference organized by Departments of Otorinolaringology. As usual, this CPC is both for the undergraduate and the postgraduate student. We would like to present very interesting case on patients with tinnitus with a mass inside the middle ear. Before I begin with the introductions, I think everyone's not very sure and clear regarding the management of patient with tinnitus and the middle ear mass. So I would like now to introduce the first speaker, who is Dr. Siti Noor Afiqah Sharudin, our postgraduate students. And the second speaker is Dr. Ho Han Guan from Departments of Radiology. And the third speaker is Associate Professor Dr. Dina Hashim. And the last speaker is Dr. Nabila Mansor. So now I would like to invite the first speaker, which is Dr. Noor Afiqah, to present the case.
Thank you, Prof. Asma, for the introduction. Now I would like, let me share my screen. Now I would like to proceed with the case presentation. This is a 39-year-old gentleman presented with left intermittent tinnitus for 10 years. It was buzzing in nature, non-pulsatile. At first, it did not disturb him much and was ignorable. Subsequently, he noticed that his left hearing has gradually reduced. However, he did not seek for medical attention as the symptoms were not troubling him. In 2017, he noticed an asymmetrical facial expression and intermittent facial twitching of the left side of his face. However, he did not seek professional advice as it did not disrupt his daily function. In 2020, his left tinnitus became persistent and disturbing. His left hearing was also worsening, causing him to have difficulty to communicate in noisy surroundings. He also raised concern as his older brother, who had similar symptoms, was diagnosed with an intracranial tumor. Otherwise, he has no active ear symptoms such as ear discharge, otalgia, ear fullness, or vertigo. He did not rhinitis symptoms, epistaxis of nasal blockage, or dysphagia or any change of voice. His appetite was normal with some weight gain over the years. For past medical history, he is diagnosed with immunoglobulin A nephropathy in 2004, which under our nephrology follow-up. Hypertension secondary to immunoglobulin A nephropathy, secondary polycythemia, moderate obstructive sleep apnea, and also gouty arthritis. For past surgical history, he has an uneventful tonsillectomy, which was done in 2008. He has non-allergy history. Currently, he's on telmisartan, perindopril, and also allopurinol. For social history, he is married and blessed with 2 children, worked as accountant, ex-smoker, which is stopped smoking since 2017, and non-alcohol consumer. For family history, he has an older brother who has underlying acoustic neuroma. Let's proceed with the physical examination. This is a picture of the patient. For general examination, we can see this is an overweight young man sitting comfortably on the chair. What do you think about his facial expression at rest? He has a left-sided facial asymmetry, House Braidman grade 2. For ear examination, the pinna was normal position and size. There's no scar seen over the preauricular, postauricular, and end-aural area. No tenderness upon pulling the pinna or over the cymba concha, tragus, and also mastoid region. At mastoid region, we can see there's no overlying skin changes or swelling palpable. Now, for autoendoscopy examination, as we can see in this video, in the left ear, there's a normal ear canal patency with minimal earwax. There's an intact tympanic membrane with whitish mass at the posterior quadrant medial to the tympanic membrane. It is a non-pulsatile. For the right tympanic membrane, it is a minimal earwax with intact tympanic membrane. So this is the picture of autoendoscopy of both a tympanic membrane. We can see the right ear and also the left ear. we proceed with the hearing assessment of this patient. For tuning Fox test, for Rini, it is positive over the right and also positive over the left side, and Weber lateralized to the left side. So I would like to ask the audience, what is we can conclude from this tuning Fox test?
Assalamualaikum and a very good morning. I'm Dr. Azhar, a third year postgraduate student. I would like to try to answer the question based on the tuning fork test. We can conclude that this patient had left conductive hearing loss.
Thank you, Dr. Azhar, for the answer. Yes, this patient currently have a left conductive hearing loss. For free field voice test, for the right ear, he able to repeat a whisper at 2 feet, suggestive of normal to mild hearing loss. Whereby the left one is able to repeat conversation at 2 feet, suggestive of moderate hearing loss. This is the facial nerve examination of the patient. As we can see at rest, there's a slight asymmetry. We can see there's a loss of left nasolabial fold and also the wrinkle over the left forehead. Upon minimal closure of the eyes, we can see there's a complete closure. On maximal effort, we can see there's a reduced orbicularis oculi over the left side. And upon smiling, we can see there is a slightly reduced the left nasolabial fold. Let me remind everyone regarding the house treatment grading. We have a 6 grading, and this patient have a grade 2 with mild function, which we saw easily and complete closure of eyes and on minimal effort. The slight asymmetrical on mouth. And also there's a reduced forehead wrinkles over the left side. For nasal examination, the cold spatula test is equal misting bilaterally. For anterior rhinoscopy, he has a right deviated nasal septum with bilateral inferior turbinate hypertrophy, and there is no mass detected. For intraoral examination, the uvula is central with tonsil grade 1 bilaterally, no lateral pharyngeal wall medialization or suspicious oral ulcer or mass seen. Other cranial nerve examination were normal. This is the baseline pure tone audiometry, which was done in December 2021. The right ear, we can see there's a normal hearing with moderate sensory neural hearing loss at high frequency, whereby the left ear, we have a mild to moderate mixed hearing loss. This is the tympanometry of the patient. We can see the both side, right and left, is bilaterally type A, showing the normal middle ear function. For case summary, is a 39-year-old gentleman presented with left non-pulsatile persistent tinnitus and worsening hearing loss for 10 years. A left facial asymmetry, house treatment grade 2 was observed. The otoscopy examination shows a middle ear mass. The audiogram depicted a mild to moderate left mixed hearing loss. What are the differential diagnoses that we can get from this case? One, we can have a facial nerve schwannoma. Second, congenital cholesteatoma. The third is middle ear paraganglioma, and the fourth one is facial nerve hemangioma. For facial nerve schwannoma, the points for pertaining to this case is the age distribution, which is from the 3rd to 6th decade of life. There's a facial nerve paralysis or palsy. There's a mass medial to the tympanic membrane, unilateral hearing loss, and also non-pulsatile tinnitus. For points against this diagnosis is there's no obvious facial asymmetry or facial dysfunction. For the second, our differential is congenital cholesteatoma. The point for pertaining to this case, there's no prior history of otorrhea or other ear symptoms. There's a whitish mass medial to the tympanic membrane. There's an intact tympanic membrane. There's no history of surgical procedure, and it is commonly in the posterior or anterosuperior quadrant of the tympanic membrane. For points against this diagnosis is usually diagnosed in infancy or in early childhood at the age of 4 to 5 years old, may present with normal hearing or conductive hearing loss, or usually diagnosed by accident. For middle ear paraganglioma, points 4 is age distribution at the 4th to 5th decades of life, facial nerve palsy, and unilateral hearing loss. for points against this diagnosis is secreting paraganglioma with neuroendocrine symptoms, pulsatile tinnitus, and red pulsatile mass medial to the tympanic membrane. For the our last differential diagnosis is facial nerve hemangioma. Points for, in this case, is progressive facial nerve palsy associated with hemifacial spasm and unilateral hearing loss. But points against this diagnosis is reddish bluish mass medial to the tympanic membrane, pulsatile tinnitus, and also it is a very rare tumor. Now I will proceed, I will pass to Dr. Han to proceed with the imaging.
Good morning, everyone. My name is Dr. Ho Han Guan. I'm a radiologist. Thank you for having me. It's my great pleasure to share with you some knowledge on middle ear disease. So in the next following 10 minutes, I would like to talk about the anatomy of middle ear cavity, mainly based on the HRCT temporal bone. Then I shall discuss on how we use HRCT temporal bone and MRI scan to clinch the diagnosis of facial nerve schwannoma for this index case. And I shall further explain the other possible differential diagnosis wherever we encounter a hearing loss or tinnitus with the presence of middle ear mass. The protocol used for the imaging of middle ear is dominated by CT scan. We use MRI infrequently as a problem-solving tool. CT is the main workhorse. Thin section CT images, usually less than 1 millimeter, will be obtained. Generally, this CT scan is done without contrast, except that it features clinically suspected a vascular lesion. For the MRI, we added fast spin echo diffusion weighted imaging. Its main purpose is to identify cholesteatoma, which is one of the differential diagnoses, and MR angiogram will be added for vascular lesion. As we know, MR is the best imaging modality to assess enhancement of the mass due to superior soft tissue contrast resolution. So let us look at a simple pictorial guide to the middle ear cavity anatomy. So this is a HRCT temporal bone in the coronal view. We can see that this is the malleus and incus, which appear to have love or heart-shaped configuration in this coronal view. Then we can see a cochlea, which is a spiral structure in the inner ear, which looks like a shell of the snail. The bony protuberance overlying the cochlea is a crucial imaging area. We name it as a cochlear promontory. A sharp triangular shaped bone between the external and middle ear is the scutum, and the space right beside this scutum is called Prusak space. This is a HRCT axial view at the epitympanium level, which is the highest level in the middle ear cavity. We can spot easily the well-recognized ice cream cone appearance, which formed by the head of malleus and body of incus. Then we can see an hourglass configuration formed by epitympanium, mastoid antrum, which connected by epithelius antrum. In our case, it's important to familiarize with facial nerve canal segments in HRCT temporal bone. Here we can see the internal auditory canal, where we can find the intracanalicular segment of facial nerve. Then we follow the IAC anteriorly, we will see the labyrinthine segment. And then the most anterior portion will be the first genu, is where the geniculate ganglion of the facial nerve is situated. From the first genu, will turn posteriorly, become the tympanic segment, or we call it horizontal segment. And here we can see the vestibule and cochlea as part of the inner ear structures. At the end of the tympanic segment, it will become the second genu, which then they become the intramastoid or mastoid segment of facial nerve, right behind the pyramidal eminence. This is cochlear promontory shown in axial view. And this is the coronal view, where we can see a vertically orientated mastoid segment of facial nerve canal. And it will open as the stylomastoid foramen for the facial nerve canal, and it will continue as an extratemporal segment within the parotid salivary gland. So now we see how we reach the diagnosis of facial nerve schwannoma, in this case by using HRCT temporal bone and MRI scan. First of all, we can see this is the HRCT temporal bone for the left side of our patient. We can spot there is a large soft tissue occupying the middle ear and mastoid A cells. Is there any bony expansion? Yes, there is a first junule of the facial nerve canal is widely open and widely expanded. And the labyrinthine segment appear normal, and the ISC also appear normal. And this is a soft tissue within the left middle ear and mastoid hair cells. And we can see that there is a erosion of the septation within the mastoid hair cells, and also the tympanic segment, which is supposed to be the red area here, which is small and narrow, but in this case is widened by the mass, and there is an erosion of the lateral wall of the tympanic segment of facial nerve canal. And this is a axial CT scan slightly higher than the previous axial images. We can see this soft tissue mass occupying more on the medial aspect of middle ear cavity, displacing our ice cream cone, the middle ear ossicles laterally. But the Broussard space is clear. There is no soft tissue in the Broussard space. And now this is the coronal view. We can see the contralateral side, which is a normal mastoid segment, which is small, narrow, and very sharp and well-defined margin. And you compare to the left side, the left mastoid segment is widened by the mass and is clearly eroded and irregular margin. And this is 3 selected axial MRI images in T1, T2, and T1 weighted post-contrast. MRI is good to assess the enhancement and the extension of the lesion. We can see there is clearly the enhancement of this left middle ear soft tissue comparing the T1 and T1 post-contrast is brighter on post-contrast images. And in the center, this is the T2 sequence. T2 sequence is very good for us to differentiate between the tumor and the mastoid effusion, which has a high signal intensity, which clearly depicted as a mastoid effusion. So this is the diffusion weighted imaging, which is a spatial sequence that we try to see is there any bright signals shown by the mass. If there is a bright signal, we call it restricted diffusion. And if there is a restricted diffusion in TWI, it will indicate this is the cholesteatoma, which we cannot see any bright signal in our case. So overall, the HRCT and MRI features are suggestive of facial nerve schwannoma because there is an enhancing middle ear cavity mass with the expansion of the genicular ganglion, tympanic mastoid segments of the facial nerve canal, as well as the stylomastoid foramen. So as a radiologist, when we encounter a clinical scenario of hearing loss or tinnitus with middle ear mass, there are a few differential diagnoses which we need to consider. So the differential diagnoses to be considered such as the congenital cholesteatoma, paraganglioma, especially the glomus tympanicum, facial nerve hemangioma, or any vascular anomalies such as apparent ICA or persistent stabilizer artery. The other differential diagnosis to consider is the middle ear inflammation and cholesterol granuloma, petrous appendicitis, which is a surgical emergency, and also we cannot forget the perineural parotic malignancy. So I would like to explain further on this differential diagnosis with some example cases. This is an 18-year-old male with the left conductive hearing loss. You can see this is the HRCT temporal bone, and we can see the soft tissue mass occupying the epitympanium, mainly in the Broussard space, and the scrotum is planted in this case. This is the typical imaging features of cholesteatoma. And on TWI MRI scan, we can see this mass showing a high signal indicating a restricted diffusion, which is the typical characteristic for cholesteatoma. And this another patient, 40-year-old female with pulsatile tinnitus and soft tissue mass with a middle ear soft tissue mass. And this is a HRCT scan. We can see there is a soft tissue mass occupying the meso and hypotympanium rather than in the epitympanium. And if we see in the axial view, this is the internal carotid canal. There is no communication between the middle ear mass and the internal carotid canal. If our ENT colleagues saw a red mass on the auto-endoscopic exam, this is a typical for paraganglioma, glomus tympanicum. And there is another, exactly the same case, same presenting complaint, but in this case, if we see the axial view, there is a communication between this middle ear mass on the right side with the internal carotid canal. This is not a tumor. This is an apparent internal carotid artery. That's why imaging is very important. Biopsy should not be taken for this kind of case. And there is another case of 40-year-old male with right facial nerve palsy. We can see there is an erosion over the tympanic segment of the right facial nerve canal with amorphous calcification of bony spicule. This is an example of facial nerve hemangioma, which we cannot see in our case. There is no calcification or enormous bony spicule in our index case. So this is another patient, adult patient with bilateral conductive hearing loss with ear discharge. We can see complete ossification of both middle ears and mastoid areas. If clinically we see a ear discharge and suspecting of the infection, these are examples of bilateral otomastoiditis, where clinical correlation is very important and crucial for radiologists to derive to the diagnosis. And this another, the last case for me, there is a 38-year-old female sensory neural hearing loss and facial weakness. We can see this the MRI scan. On MRI T1, there is a hyper intense lesion on T1 with the imaging over the left petrous apex. And there is no clear enhancement. On T2 is hyper intense with a peripheral low signal intensity indicating a hemosiderin deposition. On CT scan, there is a wide expansion of the left petrous apex. This is the typical for cholesterol granuloma. So primary malignancy in middle ear is very uncommon. Most likely it will be a skin cancer from EAC. And in children, we're thinking of the rhabdomyosarcoma or lymphoma. So in summary, when we encounter the middle ear mass, we think about the location, whether it's located at the epitympanum, which more likely will be cholesteatoma, or whether it's overlying the cochlear promontory. Or can it be a normal structure such as the apparent in ICA? Is there any bony destruction which indicating of cholesteatoma or paraganglioma, which usually have a permeative erosion of the bone? For the expansion, is there any the mastoid areas or the petrous apex is expanded by the mass? We are thinking of the cholesterol granuloma. If there is a facial nerve canal expansion, the differential diagnosis would be schwannoma or hemangioma. For the enhancement, we will assess by MRI. If there is no enhancement, we are thinking of cholesteatoma. There are some characteristic findings such as high signal on DWI will be indicative of cholesteatoma, or high signal intensity on T1 will be cholesterol granuloma. Thank you.
Thank you, Dr. Han. Very interesting description. So now I would like to invite the third presenter, which is Associate Professor Dr. Dina.
Right. Assalamualaikum, and thank you to Prof. Asma, the moderator. We had all heard a very interesting presentation from Dr. Afiqah and interesting description from Dr. Han. So as we gather all information from the case presentation and clinical findings, and assisted by imaging findings, we can conclude that the patient provisional diagnosis is left facial schwannoma. So we discussed with the patient the options of treatment. So these are the list of options that were offered to the patient. First, conservative, as if wait and see or watchful waiting, plus regular follow-up, considering that the patient has had the symptoms for 10 years. And the presentation to us, as of when he presented to us, he had no significant facial asymmetry and hearing loss. The other option was offered was surgery, in which the tumor will be removed with risk of worsening of facial asymmetry and hearing loss. And if he considered both of these options, of course, regular imaging surveillance must still be done. So then he opted to go for surgery. He underwent left mastoid aspiration and debulking of tumor via transmastoid approach on the 10th of January 2022. So postgraduates, he went through post-auricular skin approach. And then this is a video of cortical musculectomy. If you can see here, we use a huge burr. And as mentioned, if you remember, as mentioned by Dr. Han Guan, there's lots of tissue in the middle ear cavity. So we have to be careful to ensure and differentiate whether there's a granulation tissue or the tumor itself, and of course, the main facial nerve. Okay, so and then now the mustard air cell has been drilled off. And if you can see here, we are using a small burr as we go already deep into the mustard cavity. And now we can already see the mass along the pathway of the vertical segment of the facial nerve. This is a tumor. You see the difference between the tumor and the granulation tissue that was earlier seen, and there's a lot of bleeding. So throughout the surgery, facial nerve monitoring must be used and is used and is regularly stimulated to ensure that we do not disturb or traumatize the facial nerve. The stimulation has gone down, down to 0.2 milliampere to differentiate the facial nerve and the mass. And then, I just was what we remove the tumor bits by bits, slowly debulking it and separating it from the main facial nerve. And you can see how challenging it is because there's a lot of tumor, there's a lot of bleeding, and of course we have to identify the middle ear ossicles, because as mentioned earlier, the ossicles are all intact, and the hearing status is mild, moderate, conductive, mixed hearing loss. So we found that the incus is actually smaller, most probably compressed by the tumor that has grown gradually. Okay, so that's what we did, removing the tumor bits by bits, and that's the facial nerve monitor, trying to identify the facial nerve second genu at this area, and then as we go along, there's the vertical segment. Okay, so we removed the vertical segment and the second genu part of the tumor, and however, the middle ear part is left behind to reduce the risk of injury to facial nerve and also the ossicles. So immediate post-op, the facial asymmetry of the patient in the ward did not worsen. Okay, so the histopathology of the specimen, and it was analyzed, and there were a lot of spindle type cells with hypercellularity antennae type A and hypocellularity antennae type B, which was stained positive with S100 IHC analysis, and this concluded to a diagnosis of schwannoma. Okay, after 2 weeks, we saw the patient. This is how he presented to us. Well, I think that the patient has no significant asymmetry, and this is a finding of the otoscopic finding on that presentation. What do you think about the findings? So if you can see, oh, okay, we have someone who wants to try.
Good morning, Prof. I'm Mariam, first year postgrad ORL. I would like to try the auto endoscopy examination finding with similar finding operatively. I can see there's mass appears similar in size from here, and then it's similar to the tympanic membrane.
Right. So if you can all see here, the mass is obviously still seen through the endoscopic examination, medial to the tympanic membrane. Remember that I mentioned just now, we did not remove the middle ear portion of the mass to reduce the risk of traumatizing the facial nerve and worsening of hearing. So, but he claims that the tinnitus has improved, his hearing has improved as compared to the operative presentation. On clinical examination, the facial nerve asymmetry is still at grade 2 and it is not worsening. Okay, we followed him up at 2 months post-operatively, and this is how he presented to us. And you can see here there is no obvious facial asymmetry at rest, no obvious difference of wrinkles on the forehead. He was able to close his eye with force, and it looks similar both sides. And upon smiling, there's no obvious reduction of nasolabial fold on the left side. And here, at 7 months post-op, he claims that his tinnitus is present. However, it is intermittent at this point, no longer continuous. There's no more left facial twitching. His hearing has improved, and there's no obvious facial asymmetry at rest, which again suggests there's no worsening of presentation after surgery. Otoscopy also showed still the presence of tumor, but you can see there's a difference in the size, that it has become smaller. Okay, I just lined up his presentation of facial examination from first that he presented to us preoperatively. You can see reduction of nasolabial fold on the left side, and post-op 2 weeks, and at 2 months, and also at 7 months. Well, I would say that he has no, I mean, we do not notice any facial asymmetry and difference of asymmetry of the face. And this is the otoscopic examination. Preoperatively, you can see a huge tumor medial to the tympanic membrane, whitish tumor. Post-op 2 weeks, and then next 2 months, it has reduced in size. And at 7 months post-op, it has reduced in size further. Okay, so remember that I mentioned that the patient must go for a surveillance imaging, especially when we do not remove the tumor or completely. So if you can see here, the imaging before operation and after a year post-operatively, we can see a significant reduction in the size of tumor. And this is an axial cut. You can also see reduction of size of tumor, and effusion in the muscle cavity has reduced as we have removed the air cells and the mastoids. Okay, that's all from me. I pass to next presenter. Thank you.
Thank you very much, Professor Madya, Dr. Noor, Dina, Hashim. Okay, my name is Dr. Nabila Mansor. So I'll be presenting on the management of the facial schwannoma. So before we start on the management of the facial schwannoma, okay, so let's get a recap of the facial nerve anatomy. So this is can see. Okay, so this is the facial nerve course, started from the cysternal segment. This is the intracanalicula segment, and this is the labyrinthine segment, and this is the geniculate ganglion, the tympanic segment, and also the mastoid segment. And as go from the stylomastoid foramen, that's the extratemporal segment or extracranial segment. And this is another view of the facial nerve course. So facts about the facial nerve schwannoma is a rare, slow-growing benign tumor arising from the Schwann cells of the nerve. So this is, as you can see, you have the unmyelinated and also myelinated nerve. And then you can see here, this is the Schwann cell. So the facial nerve schwannoma arises from the Schwann cells. So the most common tumor of facial nerve, but it is only 1% of all temporal bone tumors. Typically, it's solitary, unilateral, and also sporadic in nature, but can involve multiple segments. But the most common segments are the labyrinthine segment, geniculate, and also the tympanic segment. Age at presentation may vary, and there are no gender predilections. Now, we have our UKM retrospective study, which was in 2010, and the median age is about 46 years old. So the clinical presentation and also the imaging appearance are influenced by topographical anatomy of the facial nerve segments involved. So it can present with a facial paralysis, twitching, hemifacial spasm, or ophthalmic symptoms, including tinnitus and also hearing loss. Recurrent facial paralysis have been reported and often been misdiagnosed as Bell's palsy. In some cases, patient may not present with a facial paralysis, and it only appears at a later stage. They have a classic motor symptoms such as recurrent facial weakness, hemifacial spasm, or slowly progressive facial weakness, which are not specific for facial nerve schwannoma, therefore causes challenges in diagnosis. A retrospective study reported about 50% incidence of misdiagnosis of facial nerve schwannoma. Therefore, we have other diagnostic modalities to help to guide us towards the diagnosis. You have the high-resolution computer tomography, CT imaging, the magnetic resonance imaging, MRI, audiometry, vestibular testing, electroneugraphy, and also electromyography. Regarding the management, there are no established indication or criteria for facial nerve schwannoma treatment. However, the management strategy have evolved since 20 years old. In the early years, total resection was the main surgical intervention, but it can lead to permanent facial disfigurement, therefore requiring facial nerve reconstruction and may affect quality of life. Therefore, the goal of treatment options is to minimize the risk of injury to a functional facial nerve. Our current management strategy involves tumor stripping, debulking, or subtotal resection, decompression, stereotactic radiosurgery, and observation. So the management depends on the facial nerve functions, hearing status, height and size of the tumor, and it can be divided into observation or wait and see, tumor resection, surgical decompressions, and stereotactic radiosurgery. Regarding observation and wait and see, it is suitable for those with a normal facial function, it's either house member grade 1 or 2, small tumor, elderly with comorbidities. So basically, it allows patients to maintain the facial nerve for a long time without having to intervene with a more destructive or invasive approach. It should be maintained until the facial function deteriorates, either it becomes grade 3 or worse, or the tumor grows significantly in size. Serial imaging is required to monitor the tumor progression. However, interval may be variable. In some centers, it can repeat 1 year or 2 years. It depends on the patient's symptoms as well. For regarding tumor resection, we talk about complete resection, must come along with the cable grafting. So it's limited for those with a severe facial nerve dysfunction, more than hospital grade 4 or more, poor hearing, large tumor that is prone to growth, and nerve graft harvested either from greater auricular nerve, sural nerve, hypoglossal nerve, or direct anastomosis. Preoperative facial nerve status is a predictor of post-grafting function. So those with a better preoperative function, for example, those with a hospital grade 1 or 2 will do better with grafting. It is a good long-term tumor control. Regarding tumor debulking, stripping, or subtotal resection is a choice of treatment. Those with a mild facial dysfunction, such as in our case, is the removal of tumor or debulking of the tumor while keeping the anatomy and the functional integrity of the facial nerve intact. It is performed under high magnification, microdissection between the nerve fibers of tumor. So you can remove the tumor from the facial fibers. So continuous electromyography facial nerve monitoring is required. Post-operative facial nerve function is expected to be maintained, the hospital grade 1 or 2. And tumor residual or regrowth should be advised. Therefore, serial MRI is also required to monitor the tumor growth. Regarding the tumor, the surgical approaches, it also depends on the location and size of the tumor as well as hearing status. So the approaches are medial craniofossa approach, transmastoid approach, combined medial craniofossa transmastoid approach, translabyrinthine approach, a retrosigmoid approach, and also endoscopic approach. So this is the summaries of the surgical approaches. As you can see, it is defined by the tumor size, tumor location, and also hearing status. Now we go to the hearing status, okay? It divided into serviceable and also non-serviceable hearing. I would like to ask any of the audience or from the floor who would like to define what is the meaning of serviceable hearing.
Assalamualaikum, Miss. I would like to try to answer. So I'm Dr. Hau from ENT department, postgraduate student. So for serviceable hearing, it is defined as a hearing threshold with equal or less than 50 decibel on pure tone audiometry, and on speech discrimination score is equal or more than 50%.
Thank you very much, Dr. Howard. Okay, so the only surgical approaches that's indicated for hearing with a non-serviceable hearing is translabyrinthine approach. It can indicated for any tumor location extending to the CP angle tumor. And for small tumor, endoscopy approach is only limited for those tumor which is limited to the middle ear cavity and also antrum. And also for middle cranial fossa, it's also indicated for small intracranial tumor, either rising from the meatal segment until the proximal tympanic segment. And for combined middle cranial fossa and transmural is indicated for large tumor, so arises from either the meatal segment until to the mastoid or the middle ear cavity. Regarding surgical decompression, it is a first-line options in patient with a normal facial function, house membrane grade 1 or 2, small tumor, good hearing function. Technique of choice is acute facial paralysis. Okay, the purpose of it is to remove the bony facial canal along the course of the nerve to relieve the compression effect by the tumor. It will preserve the facial function, hearing ability. However, there is a risk of tumor growth. Therefore, we need serial MRI to monitor the tumor growth as well. Regarding stereotactic radiosurgery or SRS, it is indicated for tumor less than 3.5 centimeter of small tumor, good facial function, and also good hearing. It does not result in the resolution of the tumor, but the tumor growth is controlled, so therefore the volume may be reduced. It's suggested for tumor that are demonstrating growth on serial MRI or residual tumor after surgery. Post facial functions is preserved and it has a good control, approximately 90%. In some cases, facial nerve, there is facial improvement about 20%. Another prospective study by Moon et al. 2014, here remained unchanged after SRS in 14 patients. However, 3 out of 14 patients developed tinnitus. So now we go back to the case. Okay, in the latest we have latest review of the patients in October 2030, which is 22 months post-operatively. Patients have presented with no more facial nerve twitching, and hearing has improved, and tinnitus present intermittently, which indeed the patient said that it has improved a lot. And on examination, as we can see, no obvious left facial asymmetry at rest. And there's only a slight weakness of the left front fold wrinkle, and but otherwise it looks almost normal. And otoscopic examination also shows residual tumor appears smaller in volume. And this is the pure tone audiometry that was performed, shows that the left hearing has improved, in which the threshold at the mid frequency has improved from 50 to 40. So regarding the prognosis, we have to look at the facial nerve outcome. The effects of multiple factors facial nerve are not clearly demonstrated in many studies, but the one that is mostly discussed about is the degree of facial nerve palsy before surgery. In a recent study by Young et al. In 2021, indicate that the preoperative house Bergman grade has a significant effect on the final outcome. So when the facial function is house Bergman grade 3 or better at the time of surgery, obtaining the post-operative house Bergman grade 3 is very likely, meaning that the facial nerve will be maintain the same grading post-operatively. How about the risk of recurrence? The growth rate, as we all know, facial trauma is less than 1 millimeter per year, and tumor recurrence of the subtotal resection is expected. So we need monitoring by MRI, serial MRI. However, in some cases, it can be stabilized with stereotactic radiosurgery. In total resection, however, there's no recurrence observed during the follow-up of 5.1 years in a study by Regis and Roche in 2008. In another case series of 9 patients who underwent total resection, no recurrence was reported after a mean follow-up of 44 months. And the aim of the treatment for this patient is tumor debulking with facial nerve and also hearing preservation. And we have achieved both of the aims in these cases. In this case, the patient maintained pre- and post-operative facial nerve function, house membrane grade 2, and there are no post-operative complications, and hearing is actually better or similar post-operatively. And it's supported by a systemic review by Bartinder et al. In 2020, in which there's a total of 104 patients with preoperative house Bergman grade 1 and 2 who underwent stripping, surgery, or subtotal resection, such in our case. 70% maintain similar pre- and post-operative facial nerve, and about 30% have worsened facial nerve function. About 40% had worsened hearing post-operatively, and 8% subsequently had significant growth of tumor or needed revision surgery. Now we have come to the end of our sessions. Now, for the take-home message, I would like to inform all the students, especially the postgraduate and also pre-graduate students, and when you encounter patients with unilateral tinnitus, hearing loss, with ipsilateral facial palsy, warranted further investigations. There are many differential diagnoses to consider, as what being explained by our speaker before, and detailed history and physical examination is important to rule in the possible diagnosis assisted with appropriate imaging. And for undergraduate student, your physical examination is very important. When you ask the patient to, when you want to assess the patient function, you don't ask the patient to make funny faces like in this picture. So you have to assess the patient systematically. And regarding the treatment, it depends on the facial nerve function, hearing status, the size and cycloma, but you also need to take into account the patient's overall conditions as well. Therefore, I will end this bit. Thank you very much.
Thank you, Dr. Wan Nabila and all other presenters. Since we have a few more minutes, I would like to welcome burning questions from the floor, from the audience. Any questions?
Assalamualaikum. My name is Ahmad Hazwan. I am ENT postgraduate student. I would like to know the duration of follow-up for this patient in which after the surgery. Thank you.
Yeah, I'll answer that. Thank you, Amma. Well, post-operatively, we would see the patient more frequently as 3 monthly to 4 monthly. Now that we have to see the progress and then we understand that the attitude of the tumor is slow growing, then and the patient's presentation is did not show any worsening or new symptoms, we can then extend the follow-ups to a longer period. But bear in mind to always counsel the patient if the facial nerve worsen, hearing worsen, or he either develop new symptoms, that he needs to come to see us earlier. And for this patient, we had him once MRI imaging post-operatively, and that is for 1 year post-op. And we are planning to schedule another one after 3 years from the first presentation. But the thing is, there is no standard duration of how frequent you will need to follow up the patient or arrange for a serial MRI as mentioned by Dr. Nabila. But basically, I would suggest that we will see and assess the patient clinically first and schedule accordingly. All right. Thank you for the question.
Thank you, Prof.
Any other question? I would like to clarify and explain to the undergraduate student, although the postgraduate mentions that the conclusion is conductive hearing loss, when there is a positive Rinne's test on the left side, it indicates that the A-bone gap is less than 15. So in other words, this patient has a left conductive hearing loss with mild conductive hearing loss, which is the A-bone gap less than 15. Because you will get a A-bone gap more than 15, then only you have a Rinne's test is negative. Any other question? We have few more minutes. There are a few take-home messages that I would like to share regarding the patient with the facial nerve paresis. Okay, not all patients with the facial nerve paresis is considered Bell palsy. Bell palsy is based on the exclusions diagnosis. So when someone with tinnitus or someone with the reduced hearing with facial nerve palsy, then you should do otoendoscope or you can do otoscopy. So if let's say otoscopy shows there is a mass medial to the tympanic membrane, then you should refer the case to the ENT, to the Otorinolaringology. Then I would like to ask question to the postgraduate. What are the best imaging that you need to request in order to manage the patients? Anyone from the postgraduate?
Assalamualaikum, Prof. Anna here. MRI with gadolinium contrast, Prof, would be the gold standard.
Okay, so it depends on, the answer is depends on your working diagnosis, and it depends on your differential diagnosis. If let's say the patient has a mass which is bluish color, pulsatile, and then of course, if let's say you have the opportunity, you have the facilities, the best MRI with the contrast. But if let's say you have mass medial to the tympanic membrane, which is not pulsatile, white in color, then you need to request HRCT of the temporal bone for you to diagnose either congenital cholesteatoma or facial nerve schwannoma. Okay.
Prof, I actually have a question.
Okay.
If, like in this case, if there is recurrence or regrowth and with worsening symptoms, would we consider radiostatic surgery for him? Radiosurgery for him?
I would like to ask Prof. Dina to answer.
All right. There are plenty of options. If you see what has been discussed earlier by Dr. Nabila, the option will include surgical again and SRS, stereotactic surgery. At the end of the day, it's the discussion with the patient, telling the patient the pro and cons of each procedures. We have to look back, and in this case that there is a significant amount of tumor left in the immediate ear, right? Without causing the patient to have dysfunction of his presentation, kan? So if he presented to us without any clinical worsening of symptoms, but you found that on the imaging, serial imaging, I would say that we follow him up first regularly and advise if he present the symptoms worsen or any new symptoms, and we have to decide on the definitive treatment, i.e. either surgical debulking again or offer him the option of non-surgical option, stereotactic surgery. But must bear in mind, clinical presentation is the most important, and discussion with the patient. Okay, thank you. Any other questions?
Any other question? So the last question to the postgraduate student, how do you want to differentiate between a paraganglioma and a facial nerve schwannoma based on the autoendoscope? Come on.
Anyone?
How do you want to differentiate paraganglioma and facial nerve schwannoma based on autoendoscope?
Assalamualaikum, Prof. Fatia here from ENT. I would like to try. So for facial nerve schwannoma, the appearance of the tumor is whitish in color, medial to intact tympanic membrane. It is usually non-pulsatile. When paraganglioma, jugular tympanicum, it has reddish appearance in color, or some describe it as sun rising sign. And also we can appreciate the pulsatile movement of the tympanic membrane due to the mass itself. And then if we have pneumatic otoscopy, we can elicit the brown sign.
Okay, thank you, Fatia. The most important things regarding the site, if let's say the facial nerve schwannoma is mainly arise from the superior, because the tympanic segment at the superior aspect. And if let's say it's paraganglioma, either it is at the central, which is on the promontory, or from the below, from the hypotympanum. I think we can have many more questions. I would like to thank everyone for this attendance to the CPC. Hopefully everyone can get benefits with this CPC, and from the departments of ENT, I would like to congratulate everyone, the speakers. So I would like to invite everyone to give applause of appreciation in the usual manner. Okay, I think that's all from